patients with two conditions. One is Duchenne muscular dystrophy and one is spinal muscular atrophy. Before you look at these slides, look at me, because otherwise you will not understand it. Ideally, what one would like to do is to replace the gene. That is some of the work that has been done now in my tubular myopathy, you will hear later on, using gene therapy. When many of the efforts started for this condition, Duchenne in particular, to perform gene therapy was impossible for technical reasons that I will explain. And therefore, a number of tricks have been used using other molecules that instead of replacing the gene, because it was too difficult to do it at that time, just work with whatever is left by the mutation. And in actual fact, you can find that in the great majority of people with Duchenne muscular dystrophy, more than 70%, with a few tricks that I'll discuss, you can do something about that particular mutation. And in actual fact, in 100% of the patients with spinal muscular atrophy, you can also use tricks that are small molecules that, although need to be given again and again, they also help quite a lot to deal with the problem that patients have. So the antisense oligonucleotide, if you like, have really dominated for the last 10 years the field for Duchenne muscular dystrophy and spinal muscular atrophy. However, just in the last year and a half, gene therapy is certainly getting very rapid traction with quite interesting results as well. So I will start with this antisense oligonucleotide that you will not have much experience of. But before I do that, just a very quick, these are different conditions, especially Duchenne from my tubular myopathy. This is a condition that really starts at the age of 4 or 5, leads to loss of ability to walk by the age of between 9 and 12. And spinal muscular atrophy is a more severe condition. This is a condition that have really the mean age of survival of children who otherwise would not be treated is 9 months, and very few without intervention will survive past the age of 2 years. So that is a very severe condition. So in both conditions, as I said, until recently it was difficult to replace completely the gene. So what you do is, these people do not have all the gene missing, they have just a tiny bit that is missing. So can you put a plunk, can you put a patch between the two parts of the gene and make that work? Antisense oligonucleotide are patches, basically. And in this particular case, in this particular child, for example, of the many, many components that are 79 of the dystrophin gene, this child is missing one. And if you were able to remove or to obscure this particular one that is called 51 with a particular molecule, you will be able to have 52 and 51 stick together well. You can see that otherwise they don't stick together well. And this can be done using antisense oligonucleotide, and a similar concept that I'm not going to go in detail is for spinal muscular atrophy. The problem of this intervention is it doesn't work forever. You need to do it again and again. So every week in this condition, children need to have an intravenous infusion. The result of the work for Duchenne muscular dystrophy, I'm familiar with the result because we started with one particular drug here in this country, in a hospital very close, but eventually Sarepta took that forward. They've been encouraging, probably not spectacular, one will say. However, this is the number of children who received the drug, who stopped walking after 4 years of the treatment. And you can see that there was a proportion of patients who stopped walking at the very beginning, but the proportion of patients who stopped walking of the children who were not taking the disease goes from 0 to 25% to 50% to 83%. So I think this difference in slope of what's happening is an indication that the drug appears to be effective. The work in spinal muscular atrophy, if anything, is more spectacular. The difference in spinal muscular atrophy is that the condition affects the spinal cord. You need to access part of the spinal cord. And these drugs, while in Duchenne you give them intravenously, in this condition, this drug needs to be given by a needle injection in the spinal fluid. Now, it's not done every week. You know that will be highly undesirable. And this is done 4 times in the first 2 months, and then after that, every 3 months. So I think that the result of the study have been incredibly effective, to the point this is the first study I took part that was interrupted early because it was not ethical to continue with some children not receiving the drug but just placebo. And the drug was approved by FDA within 3 months. So that gives you, FDA, they are sticky. And they, if they do something like this, it's just because you have good data, not because you have other things. So the number of children who got better on the placebo was 0. The number of children who got better on the drug was more than 50%. And when I say got better, I remind you that these children, the mean age of survival is 9 months. None will sit, none will stand, none will walk. So if you realize that here, and none will roll. So you realize that, 30, these are the percentage of children who acquire the ability to roll, to sit, and to stand. And I think oops. Microsoft PowerPoint has stopped working. That is very encouraging. It's got. It's frozen. It's frozen. It's okay. I'll start it again. So I'll. It's okay. It's okay. Media will not show that. It's okay. There was a video that couldn't be live, so I will skip the video. So I had some videos there of some of the children treated. Perhaps I can show them to you afterwards. I don't want this to freeze again, and then I run out of time, because I have another important message to tell you. Actually, two. The first is that AAV gene therapy that was, for Duchenne, impossible to think about just 2 years ago, that's gaining very rapid traction. And the reason why it was difficult to think about it for Duchenne, the virus, or the viral vector where you need to put the gene, does not contain. It's like you want to squeeze a lorry in a very tight space. You can only put a small Ford Fiesta. So how can you make this Ford Fiesta work as a lorry or carry the same thing? It's very difficult. However, by engineering how this gene is function and so on, people have cut away more than 50%, half of it, and identified which one are the parts that are more essential for this gene to work. So they went to a size of the gene that can be stick into one of these vectors. The viral vector, as you are aware, will only be given once. And at the time we speak, there are 4 initiatives. There was nothing last year. There are, at the moment, 4 initiatives. And some children, the first children being treated by Jerry Mendel at Nationwide, the first data been released maybe 3 weeks ago, 2 weeks ago, for just the first 3 children after a few months. And I think that the results are certainly very encouraging, both on how these children have tolerated the drug, but also of the ability to make some of this protein produced. It's still too early to tell how well these children will be, because it will take longer time to tell. For spinal muscular atrophy, the same guy, Jerry Mendel, it's difficult to keep him quiet, does a lot of very good work. He has also done a very well-conducted clinical trial together with a company called Avexis on 2 doses of the gene for spinal muscular atrophy that is actually the right size to be put into an AAV. And they have treated children with a low dose, and I'll show you, this is what to expect of the course of how children with type 1 spinal muscular atrophy get worse with time. And these are children who receive the low dose of the drug, showing at least stability. But when you then take children who receive the high dose of this AAV vector, you realize that some of these children, especially those treated very early in the course of the disease, get remarkably better. Most children really have a response that was unprecedented and probably unexpected by many people like me. And therefore, this is highly encouraging. So I have some take-home message and some conclusion. So on the whole, for this AAV gene study so far, most of the side effects have been manageable. There has been one significant adverse event in one of the particular clinical trials, but that particular trial has started again. I think that in a way, there are issues that will need to be considered. Not all children can receive AAV because some may be already immune. I think that there is the issue that has been found again of some liver damage in the short term that needs to be addressed by giving high dose of steroid, but this was manageable. I think one thing, especially for muscular dystrophy, that is not completely clear is how long this will stay for, and whether we'll stay there forever. I think that in terms of the concluding remark, I think, certainly for spinal muscular atrophy and Duchenne, there have been progress, especially in the last year and a half, 2 years, that are incredible, I think. I think at the same time, probably it's important to realize this, that complete reversibility, meaning having people with this condition will have no problem at all after these therapies, is not going to happen for many years to come. Let's not be ambitious to the point that we are being unreasonable. And therefore, it's still important for these children to receive optimal management, optimal standard of care, so that everything is maximized. I think that clearly, in many of these conditions, there is the earlier the diagnosis, the earlier the treatment, the better the outcome. So a lot of discussion on how to reduce the delay for treatment. And the last slide is to say, actually, if you read this last part, and that is probably something you need, or your organization need to think about it very carefully. Some of these drugs cost a lot of money. Nobody wants to pay for expensive drug. And the excuse or the justification from the health service is they cost too much. Why would I spend so much money for you? The reason for this is that we, but also you, do not collect well the burden of disease, how much money, time, hours without sleeping, and so on, you spend to look after your children. This needs to be quantified, because this is eventually something that the NHS understand, or the health system understand. This is money. But I think you do need to collect this. So at the moment, for some of these drugs, although the results are outstandingly, there are hurdles for their adoption by the health system, because they're expensive, and because the cost of this condition, nobody has ever check how much it costs to have spinal muscular atrophy. Nobody knows how much it costs to have tubular myopathy. So that's important work for you to think now. And I will just stop because I'm a little, a few seconds late, and thank you for your attention.